Afternoon, everybody. You are all witness that I got permission at 3 past. This was 3 because this is 3 minutes past. We'll continue till 3 past 3. So, from the Department of Cardiology, today we are going to present a case which is remarkable for several reasons. The patient exhibited life-threatening complications and with multiple conditions appeared to be present. And we had actually not encountered a similar case in last decades. And internationally also only very few such cases have been reported. Some of the diagnostic tests that we have performed, we have not performed since 1990s. I have seen them in 1990s, but after that, this is the first time that this is being done. And this case kind of posed several challenges in management also. And despite thorough evaluation, some questions remain unanswered. It also sparked extensive debates in our departmental meetings, and some of the discussions became very heated. So we'll be discussing all the intriguing aspect of the case, and hopefully without any heated exchanges this time. Dr. Raki will be presenting the case, and after that we'll followed by comments from Dr. Nitish Nayak, Dr. Neeraj, and Dr. Deepti, and others. Dr. Raki.
Good afternoon, one and all present here. I welcome everyone for today's clinical combined rounds. The first case is from the Department of Cardiology. The title is Lambda wave ECG. It's not so Greek after all. The meaning of this title will unfold as we understand our case history. So our patient is a 35-year-old gentleman. He is a computer engineer from Delhi. So he had come to us with chief complaint of chest pain followed by syncope. This has occurred 4 times in the past week. And most of the episodes we can see, it is in the early morning or midnight. So his first episode was on February 2nd at around 3 a.m. He was sleeping and sudden onset severe retrosternal chest pain which was radiating to right chest. He woke up from sleep because of that and it was followed by transient loss of consciousness for around 2 to 3 minutes and he had full recovery of sensorium after that. And the pain had subsided after 15 minutes and then he went back to sleep. And the next day morning, he went to hospital to inquire about his previous night chest pain. But then in hospital, he developed similar episodes of chest pain followed by syncope. An immediate ECG was done and this is the ECG at that time. This appears so bizarre and dangerous as if we are seeing multiple sharks swimming in the sea. So that is because this is a normal PQRST. When there is exaggerated ST elevation, we get this triangular lambda shape QRS complexes. This is the crux of our presentation today. Apart from this, we can also notice there is bradycardia. If we see here, the red arrow where it points, there are small bumps which are occurring at regular intervals and these are the P waves. And this green arrow represents the QRS complexes. So we can see that the P is not followed by QRS complexes, which is the usual case. So here atria is pumping separately and the ventricle is pumping separately. Apart from this, there is also ST elevations in the anterior chest leads. This V2 to V6 and 1 AVL represents the anterior part of the heart, and in those anterior chest leads there is ST elevation. So a diagnosis of anterior wall myocardial infarction with complete heart block was made. So what is this lambda wave ECG? What is the difference from the unique usual ST elevations which we see? So this lambda wave ECG, lambda wave is a giant V wave which occurs because of the fusion of QRS, ST and the T waves. So this is the usual ST elevations where there is ST elevation from the baseline and there is a convexity upwards. But when this QRS complex, ST segment and the T wave gets fused, we get a triangular shaped lambda wave. And it will be a positive polarity in the leads where there is ischemia. As seen in our case, it was in the anterior part. So what is the pathophysiology of this lambda wave formation? This is most common in ACS setting. For example, if you see this first image, this is the area where there is infarction. In the area of infarction, there will be multiple local pH changes. There will be acidic environment and there will be inactivation of the ions at ion channels in that area. So there is inhomogeneity between the normal myocardium and the infarcted myocardium. And there is also inhomogeneity between the epicardium and the endocardium because of the differential concentration of the ion channels here. So because of this overall inhomogeneity of the ion channel, there is dispersion of the electrical activity leading to multiple haphazard electrical circuits which can lead to ventricular fibrillation and ventricular tachycardia, which are life-threatening. So these lambda waves are considered to be the markers of transmural electrophysiological inhomogeneity. So if we see lambda wave pattern, these are high risk for VT and VF as seen in our patient. So where all we can find these lambda waves? The most common causes ST elevation myocardial infarction in ACS setting, Takotsubo cardiomyopathy, coronary vasospasm, and also in Brugada syndrome. In the first three, the cause is inactivation of the ion channel because of ischemia, as discussed previously. In Brugada syndrome, it is an inherited channelopathy. There is pathogenesis because of genetic mutations. For the same reason, there will be heterogeneity in the epicardium and the endocardium. So coming back, this is also seen that in multiple case reports they have shown that the lambda-like ST segment elevation is a risk predictor for lethal ventricular arrhythmias. So coming back to our patient who developed this in-hospital lambda wave ECG, he was diagnosed as anterior wall myocardial infarction and he was rushed to the cath lab for angiography. But surprisingly, the angiography was normal. The coronaries was normal. So they had considered it as anterior wall myocardial infarction with spontaneous recanalization of the left coronary artery because sometimes when there is significant thrombus burden with loading doses of aspirin, there is occurrence of spontaneous recanalization of a previously occluded arteries. So patient was pain-free and he was discharged on dual antiplatelets and statins. During discharge, this was the discharge ECG. So he was pain-free. This is it appears not like normal ECG P, QRS, there is no ST segment elevations. But if we see closely, this is the RR interval and this is the QT interval. Usually, the QT interval is less than 50% of the RR interval. But here we can see the QT interval is more than 50% of the RR interval. This is a crude method to say there is QT prolongation. If we calculate properly also, the QT interval was 516 milliseconds, which is long QT when it is more than 440. Since the patient was pain-free and there is no ST segment elevations, echo was normal, angio was normal, he was discharged. On the next day only he had the third episode. He was sitting leisurely at home and at around 8 a.m. he developed significant chest pain followed by syncope and he was rushed to hospital and this was the ECG at that time, which is looking still strange and bizarre than the previous ECG. Again we can see the typical lambda appearance of the QRS complexes. Apart from that, we can also see there is no P waves, which says that there is no atrial activity and there are only ventricular activity. So there is sinus arrest. The previous ECG we also saw that the ST elevations, the lambda pattern was seen in anterior leads. But here we can see in 2, 3 and AVF, that is the inferior leads. So he was diagnosed as inferior wall myocardial infarction with sinus arrest. And progressively his chest pain had settled, but then he had tachycardia. This was the ECG during tachycardia. We can see ST elevations are still persisting in inferior leads. Apart from that, there are some different morphology of QRS complexes which are polymorphic VPCs, ventricular premature complexes, which are known to occur in ongoing ischemia. And after some time, he also developed this tachycardia with a heart rate of around 140 per minute. We can see it is a regular, relatively narrow complex tachycardia. Still there is persistence of ST elevations. A possibility of junctional tachycardia which can occur during ischemia, however ventricular tachycardia could not be ruled out. There is no P wave seen. So with this ECG, he was again rushed to cath lab because it was a inferior wall myocardial infarction. But again the coronary angiography was normal. So echo was normal, he was pain free and he was discharged from the outside hospital with antiplatelets. So with these ECGs, he had come to AIIMS emergency. When he came to emergency, he was pain free and stable. But considering his recurrent recent history of syncope and chest pain, he was admitted in CCU. We had a working diagnosis of myocardial infarction with non-obstructive coronary arteries and the cause to be evaluated. But we witnessed the arrest, witnessed the episode in the CCU. He was at around 11 p.m. He was sleeping and he had similar episode of chest pain, and this was the ECG recorded in the monitor. We can again see the lambda pattern in the 2, 3 and AVF. His vitals were stable and his echo was normal. He was given sublingual nitroglycerin, a coronary vasodilator, and followed by, after 10 minutes, the pain had subsided. And he also recalled that the pain was similar to the previous episodes. So we had increased the antianginals. These are coronary vasodilators, amlodipine from 5 mg to 10 mg, and nitrates were added. And on probing, he also said that he had similar episode in 2022, but however he did not have syncope at that time, and ECG and echo was normal, and he did not get any medical follow-up after that. And he was also a known case of hypertension since then, or well controlled on amlodipine. He had no history of sudden cardiac death, and there is no history of recreational drug use. On general physical examination, he was obese. However, other physical examination was normal. So this patient who had come with recurrent history of chest pain with different territorial involvement, like first anterior wall MI and then inferior wall MI, but with normal coronaries twice, with normal echo. So we considered maybe a transient vasospasm would have caused this, and we initially diagnosed it as vasospastic angina, and we want to prove this. So we underwent this ergonomen provocation test, which is, though guidelines indicate this as class 1 recommendation for confirmation, but we generally don't do because of the risk involved, because it can cause significant vasoconstriction and it can cause sudden cardiac arrest on table also. So we have taken all the precautionaries with the defibrillator, adequate coronary vasodilators on table with TPI. So before going in this ergonomen test, it is same as this methyl ergometrin, which we give in postpartum hemorrhage for vasoconstriction. Here we give low doses of methyl ergonomen inside the coronary artery and see how much constriction it causes. Usually low dose doesn't cause much constriction in normal people, but patients who are prone for vasospastic angina has significant vasoconstriction, more than 90%. So before going into the ergonomen test, we did a coronary angiogram, This shows this is the right coronary artery and this is the left coronary artery, and these are good caliber and normal lumen. There is no obstruction. So we went ahead with the ergonomic provocation test. This is the normal coronary angiogram for control. This is the RC and this is the LAD. First we gave in 50 microgram of ergonovin in the right coronary artery. So we can see there is significant constriction, more than 90% in the right coronary artery. And the patient also developed significant chest pain. And this left coronary injection was given as a control. Again we can see this is the normal coronaries and this is the constricted right coronary arteries. So same thing we repeated in the left coronary artery. Like right coronary artery became normal after giving nitroglycerin. So this is the left coronary artery, this is the normal, and this is the significant vasoconstriction seen in the left coronary artery, more than 90%, and the patient had significant chest pain. Again to compare, there is more than 90% compression of the left coronary artery. So it was a positive ergonovin provocation test. So we are sure that there is vasospasm and the Prince-Bettel angina is confirmed, the other name for vasospastic angina, with recurrent chest pain, significant myocardial infarction like changes in the ECG, with normal coronaries and positive ergonovin test. But is it the end? Are we missing something else? Because when we see the ECG of this patient, it is not like the usual inferior wall MI ECG which we see. This is not this patient. This is the usual inferior wall MI with ST elevations in the inferior leads. But what about our patient? It was a significant lambda-like pattern with conduction blocks. So we cannot just stop with vasospastic angina. As discussed previously, we saw the causes of lambda wave ECGs. STEMI has been ruled out by normal coronary angiogram and Takotsubo has been ruled out with normal echocardiography. And coronary vasospasm is irrefutably present. But what about Brugada syndrome, a channelopathy which can also cause lambda-like ECG pattern, and 20% of Brugada syndrome are diagnosed with chest pain. We haven't ruled out yet. And also, with the presence of impressive ST segment elevations and prolonged QT interval, if we could remember the baseline ECG, and the conduction blocks like sinus arrest and complete heart block, apart from the vasospasm, we should consider overlap of Brugada syndrome. Because for both, the connect is the channelopathy. For coronary arteries to dilate and constrict, we need multiple channels in the smooth muscle. Similarly, for the conduction system to operate in the heart, we need multiple cardiac channels. So the pathology which can connect the both is the channelopathies, which is a Brugada syndrome. So we had sent for a genetic testing, and as we suspected, we had got a mutation in the SCN5A sodium channel, which corresponds to the Brugada syndrome, though the variant was of uncertain significance. But then with the high pretest probability with such ECG changes, this has some importance, but then the association has to be confirmed by with follow-up. So a diagnosis of vasospastic angina with a possible overlap with Brugada syndrome, the channelopathy, was made. And he was started on lifestyle measures like to avoid alcohol and smoking, which can precipitate vasospasm, and he was started on anti-anginals or the coronary vasodilators, namlodipine, nicorandil, and on SOS basis nitroglycerin spray and statins. With lambda-like pattern and a possible ventricular tachycardia one episode, and with multiple conduction blocks like CHBs and sinus arrest, He was also given a dual chamber intracardiac defibrillator because he was high risk for sudden cardiac arrest. And on follow-up, now he is asymptomatic and there is no further episodes. So what is Prince-Metal angina or vasospastic angina? It was first developed by the cardiologist Myron Prince-Metal in 1959. It is this transient vasoconstriction which can cause recurrent chest pain, which mostly occurs at rest and relatively inactive periods, which is unlikely as in atherosclerotic coronary artery disease. So there are exact cause of coronary artery spasm is unknown, but there are multiple hypotheses made, including the ion channel hypothesis. So the management of vasospastic angina is nitroglycerin during acute episodes, and for chronic use we give calcium channel blockers. However, long-acting nitrate to be avoided because it can cause side effects like headache and also drug intolerance because of tachyphylaxis. Beta blockers also to be avoided because by beta-2 blockade it can cause coronary vasospasm. So patients without any high-risk features, on medications, the survival is good. However, with aborted sudden cardiac arrest and family history of sudden cardiac arrest, there is high risk of VT and VF. And this is not the first case, and there are multiple cases of Brugada syndrome associated with coronary vasospasm. So Brugada syndrome is a defect in ion channels which has vulnerability to develop VT and VF and bradycardia leading to sudden cardiac arrest in young adults. So because of this multiple ion channels, it can cause conduction blocks as described. So these are the multiple ion channels which are involved, and this SCN5A is the most common channelopathy involved in Brugada syndrome. So it's most common in the males, and the area which is affected is the right ventricular outflow tract, which causes ventricular inhomogeneity. So the conclusion is, whenever a patient comes with chest pain, typical cardiac chest pain with normal coronaries, vasospastic angina has to be considered, and ergonovin provocation test is feasible and can be done in suspected vasospastic angina. If there is a lambda-like ST elevation, there is high risk for future ventricular arrhythmias. So with impressive ST segment elevation with Prince-Metal angina, suspect associated Brugada syndrome. Thank you.
So I think so. This was an unusual case in which you had, you saw what Dr. Narang said. We have not seen these cases for many years. The symptoms seem to suggest that he was having some anginal episodes because there were provocation. There were episodes which were precipitated, in which there was preceding angina. And a test, a drug that could provoke vasospasm was showing the results, showing evidence of ischemia, in the sense that coronaries were significantly ischemic, but we didn't see provoke a syncope. So, which was a little unusual, but maybe if the test had been continued, we would have had some positive findings. At the same time, we had the unusual finding of the ECG, which was not very, which was suggesting vasospasm, but again had some things that drew our attention to other things. So two unusual things in the same patient, and I guess we will get to know more about him as we follow him up. Vasospastic angina is certainly a very important condition in him, but whether he has an associated channelopathy remains to be proven. So, Neeraj, you want to say something?
I think what stumped all of us in this patient was the very unusual and bizarre ECG, which was varying its colors and manifestations. Every time we saw this, every episode had a newer kind of ECG, sometimes this finding, that finding. So we kept on confusing whether it's Brugada or vasospastic angina. So when we proved the one diagnosis, the other was being debated. And we realized that even if we are not able to prove definitely Brugada syndrome, which is primarily an ECG diagnosis, there is some telltale evidence that it could turn out to be some sort of Brugada syndrome. And one more thing that we keep on listening about, that a lot of young patients dying, and we keep on running around that, see, there's a young patient who have died and we have to, everybody should go for like CT, angio or everything. Even this patient, angiogram was normal, baseline ECG was normal, he was being evaluated 2 years back, but still it turned out to be very rare kind of disease. So these are the conditions we cannot screen out something. What is screening? The standard screening process which we do for fluorosis stands good. These rare kinds of things that might pop up in population once in a while, but they are not supposed to be changed with like everybody should go angiogram or something like that. These are the routine screening testing we should do, and it's very unusual to pick up vasospastic angina during the episode, because this is the, by nature of the disease, it is very transient. It happens and goes off. If you are there in the hospital, you will get an incision. Otherwise, in between ECG will be normal. So I think we picked up and 2, 3 abnormal ECGs and very unusual ECGs which were like very rarely seen. So that was the beauty of it. Thank you.
Very nice case. I think there's irrefutable evidence that there is no doubt about vasospastic angina here. Typical angina at rest with spasm happening in different territories proves that it is vasospastic angina, even without a provocation test. I was not very favorable with the idea that there is associated channelopathy. We should look for it, but so far there is no evidence that there is any channelopathy associated. The ECGs are not in the typical territory, are not showing changes in the typical territories where an early repolarization syndrome or a Brugada syndrome will manifest. There is no VT in this patient so far. He hasn't had a single episode of VT or polymorphic VT or VF, which is usually described in these channelopathies. The QTC prolongation, I'll take it with a pinch of salt. It was done 1 day after his first episode. He's tachycardic at that time, which means that it is during the episode of ischemia or just after ischemia. And if the calculation is from Bezets, I think, but if he
Debate so far has been very civilized because everyone has been present in front of camera. But in the department we had much more day. So the house is open. I mean, debate. This case is open for discussion.
Right, so you seem to be unable to decide whether Brugada syndrome is there or not. Everyone is agreed that there is. Will your management change based on whether he actually has Brugada or not?
Right. So the management, the main thing is that he definitely needs an ICD. He would definitely need an ICD, and the choice of antiarrhythmic agents will also be a little affected. Whether he has Brugada or he has a long QT as a primary thing, or vasospasm at the only thing without any channelopathy, or some other channelopathy genetically directed. So it will make a difference to the antiarrhythmic therapy. But as far as the prevention of subsequent episode is concerned, ICD had to be given. That will be there.
So this is very interesting and very rare case, seems to me. When we tried the broken replacement problem in one artery, right side, right coronary artery, was it necessary to inject the left coronary?
Right. That's a very good question, because it can happen that the injection into one coronary artery, Argoni injection in one coronary, may lead to spasm in the other coronary artery. So to have a more comprehensive evaluation, both should be done. However, in vast majority of cases, it is the same coronary artery which shows spasm. So your point is well taken. It could have been done in only single coronary artery, but since two arterial kind of access could be obtained easily, both were done basically. There is a slide, but in the controlled environment it is possible. But for more comprehensive evaluation, especially in the difficult case where the diagnosis is not clear, that is why it was done.
Is it always this vasospastic angina Lambda is silent color to diagnosis?
Not really. The ST elevation is the classically what is mentioned. ST elevation is the classical feature of vasospastic angina, which is reversible. However, lambda pattern can also occur, but that is a confusion because it could be because of channelopathy rather than because repeatedly the same time. But in a particular patient, the same pattern of ECG abnormality can occur.
Lambda will actually have this marker for certain cardiac arrest. So once you see Lambda ECG, then in the estimation at my normal automatic MI can also do Lambda ECG. That is for certain cardiac arrest.
Okay, I see that we have finally exceeded our time. Thank you very much.